Nausea and vomiting. Clinical lecture notes. Nausea and vomiting are not just symptoms. They are experiences every one of us knows too well, yet in clinical practice they can signal anything from a benign self-limiting illness to a life-threatening emergency. Every patient who vomits is telling a story of the gut, the brain, drugs, hormones, or a system under stress. Our job is to listen carefully, decode the pathways, and act decisively. In this clinical lecture, we will go beyond the reflex. We will explore the neural pathways that trigger vomiting, master the causes and red flags, understand how to diagnose with precision, and learn to treat and prevent effectively, from antiemetic drugs to fluid and electrolyte management, PONV prevention, and the critical risk of pulmonary aspiration. The goal is simple: better knowledge, better care, better outcomes. Let us begin. Learning objectives. 1. Define nausea, vomiting, retching and regurgitation. 2. Explain the physiology and neural pathways. 3. Identify common and dangerous causes. 4. Assess, investigate and manage patients. 5. Discuss antiemetics and PONV. 6. Recognize aspiration risk and complications. Definitions. 1. Nausea. Unpleasant subjective sensation with an urge to vomit. It is the conscious awareness that vomiting may occur, often the earliest warning. 2. Vomiting, emesis, forceful expulsion of GI contents. Results from coordinated contraction diaphragm, abdominal muscles and stomach against a closed glottis. 3. Retching, rhythmic contractions without expulsion. Represents an effort to vomit but without actual ejection of gastric contents. 4. Regurgitation, passive return of gastric contents to the mouth. Occurs without nausea or abdominal muscular effort, due to pressure gradient or sphincter failure. Why it matters. 1. Very common symptom across emergency, ward, obstetric and perioperative care. Almost every specialty encounters nausea and vomiting, so all clinicians must know how to handle it. 2. May indicate serious disease. Be the presenting feature of bowel obstruction, raised intracranial pressure, or metabolic emergency. 3. Can cause dehydration and electrolyte abnormalities. Repeated vomiting leads to loss of water, acid, and potassium, affecting circulation and heart rhythm. 4. Important risk. Aspiration of gastric contents. Vomiting impairs airway protection, especially under sedation or anesthesia, leading to chemical pneumonitis. 5. PONV may delay recovery and discharge. Postoperative nausea and vomiting increases patient distress, prolongs stay, and raises healthcare costs. Physiology of vomiting. 1. Complex protective reflex coordinated by the brainstem. The brainstem acts as a central integrator to expel harmful substances and protect the body. 2. Inputs arise from GI tract, blood-borne toxins, drugs, vestibular and higher centers. Multiple sensory sources converge on the vomiting center to detect threat. 3. Output coordinates diaphragm, abdominal muscles, stomach, esophagus and airway. Coordinated muscle activity creates high abdominal pressure while protecting the airway. 4. Nausea, retching and vomiting may occur sequentially. These stages represent increasing intensity of the same reflex arc. Neural pathways. 1. Chemoreceptor trigger zone, CTZ, area postrema. Detects toxins, drugs and metabolic changes in blood and CSF, as it lies outside the blood-brain barrier. 2. Nucleus tractus solitarius, NTS. Main integrative center that receives most afferent signals and initiates the vomiting response. 3. Vagal afferents from the GI tract. Carry signals from gut stretch, irritation and inflammation to the brainstem. 4. Vestibular system. Mediate motion-induced nausea and vomiting through connections to the vomiting center. 5. Higher cortical limbic inputs. Emotional, visual and olfactory stimuli can trigger vomiting via cortical pathways. 6. Medullary vomiting network coordinates the response, integrates all inputs and orchestrates the motor output for retching and vomiting. Important receptors. 1. 5-HT3, GI tract, vagal afferents and brainstem. Mediates gut irritation and chemotherapy-induced vomiting signals. 2. D2, CTZ and central pathways. Dopamine receptor active by drugs, toxins and metabolic disturbances. 3. H1 and M1, vestibular pathways. Histamine and muscarinic receptors involved in motion sickness and inner ear disorders. 4. NK1, central emetic pathways. SUNS-P receptor that sustains vomiting in the brainstem, especially in delayed emesis. 5. These receptors are major antiemetic drug targets. Blocking them explains how different antiemetics work at specific sites. Causes. Gastrointestinal. 1. Gastroenteritis. Infection or inflammation irritates the stomach and intestines, triggering vagal afferents. 2. Gastritis, peptic ulcer disease. Mucosal irritation and acid increase afferent signals that stimulate the vomiting center. 3. Appendicitis. Visceral inflammation and peritoneal irritation cause reflex vomiting via sympathetic and vagal pathways. 4. Cholecystitis, pancreatitis. Biliary and pancreatic inflammation produce severe visceral and reflex emesis. 5. Intestinal obstruction, ileus. Distension and stasis activate stretch receptors and lead to reverse peristalsis. 6. Peritonitis. Diffuse peritoneal inflammation causes widespread autonomic stimulation and vomiting. 7. GI bleeding. Blood in the gut acts as an irritant and may trigger vomiting, sometimes with hematemesis. Causes. Non-GI. 1. Pregnancy, hyperemesis gravidarum. Hormonal changes, especially HCG, stimulate the CTZ and lower the vomiting threshold. 2. Migraine and vestibular disorders. Vestibular and trigeminal pathways activate central emetic circuits through H1 and M1 receptors. 3. Raised intracranial pressure, CNS disease. Increased pressure or direct lesion irritates the brainstem vomiting centers. 4. Metabolic, hypoglycemia, DKA, uremia, hypercalcemia. Blood-borne metabolites and toxins act directly on the CTZ outside the blood-brain barrier. 5. Drug-toxin effects. Chemotherapy, opioids and other drugs activate CTZ receptors and gut vagal afferents. 6. Anxiety and other higher center triggers. Cortical and limbic inputs can initiate vomiting through emotional and conditioned pathways. History. 1. Onset, duration and frequency. Helps distinguish acute self-limited causes from chronic or progressive pathology. 2. Character. Food, bile, blood, coffee ground material. Content suggests level of obstruction or bleeding. Bile indicates patency beyond pylorus. Blood suggests mucosal injury. 3. Abdominal pain, diarrhea, fever, headache, vertigo. Associated symptoms guide localization, whether GI, CNS, vestibular or systemic. 4. Medication and toxin exposure. Many drugs and toxins act on CTZ or gut, so exposure history identifies reversible causes. 5. Pregnancy possibility. Essential in any woman of reproductive age, as pregnancy alters differential management. 6. Previous episodes, surgery and comorbidities. Recurrence, adhesions, or metabolic disease can predispose to vomiting. 7. Hydration and urine output. Indicates severity of fluid loss and helps prioritize resuscitation. Examination. 1. ABCDE in an unstable patient. Systematic approach identifies airway, breathing and circulation threats before detailed assessment. 2. Vital signs and mental status. Tachycardia, hypotension, fever, altered consciousness point to sepsis, dehydration or CNS cause. 3. Hydration, mucous membranes, perfusion, urine output. Dry mucosa, prolonged capillary refill and oliguria reflect severity of fluid and electrolyte loss. 4. Abdominal, distension, tenderness, guarding, bowel sounds. Distension with hyperactive sounds suggests obstruction, while absent sounds and rigidity suggest peritonitis or ileus. 5. Neurological examination when indicated. Focal deficits, edema or nystagmus help identify raised ICP, migraine or vestibular disease. 6. Assess aspiration, airway risk. Reduced consciousness, absent gag or ongoing vomiting increases risk of aspiration and airway compromise. Red flags. 1. Hematemesis or significant GI bleeding. Suggests active upper GI bleeding that may require urgent endoscopy and transfusion. 2. Severe or localized abdominal pain. May indicate surgical pathology such as appendicitis, cholecystitis, pancreatitis or ischemia. 3. Abdominal rigidity, distension. Rigidity suggests peritonitis. Distension suggests obstruction or ileus needing urgent evaluation. 4. Shock, severe dehydration or oliguria. Reflects severe volume loss or sepsis and requires immediate fluid resuscitation. 5. Altered consciousness. Raises concern for CNS pathology, severe metabolic derangement or aspiration risk. 6. Severe headache, meningism or focal deficit. Suggests raised intracranial pressure, meningitis or intracranial lesion. 7. Persistent projectile vomiting. Projectile pattern suggests pyloric or raised ICP. Persistence increases risk of complications. 8. Pregnancy with severe vomiting. Risk of hyperemesis, dehydration and electrolyte disturbance affecting both mother and fetus. Investigations. 1. Targeted investigations based on clinical suspicion. Avoids unnecessary tests and focuses on the most likely underlying cause. 2. FBC, electrolytes, urea, creatinine and glucose when indicated. Identify anemia, infection, renal impairment, electrolyte imbalance and hyperglycemia from fluid loss. 3. Pregnancy test when appropriate. Essential to exclude pregnancy-related cause in any woman of reproductive age with vomiting. 4. Keeps blood gas in suspected DKA or severe illness. Detects metabolic acidosis and ketoacidosis which can present with vomiting. 5. LFTs, lipase, amylase when indicated. Helps evaluate hepatobiliary or pancreatic inflammation as a cause of vomit. 6. ECG when electrolyte per quart drug risk exists. Electrolyte shifts and antiemetics can prolong QT, so ECG assesses arrhythmia risk. 7. Imaging, endoscopy according to suspected pathology. Ultrasound, core, X-ray or endoscopy chosen based on signs of obstruction, peritonitis or bleeding. Complications. 1. Dehydration and hypovolemia. Repeated fluid loss reduces intravascular volume leading to hypotension and tachycardia. 2. Hypokalemia, hypochloremia and other electrolyte disturbances. Vomiting loses gastric electrolyte triggers secondary renal losses. 3. Metabolic alkalosis after significant gastric acid loss. Loss of hydrochloric acid raises blood pH and impairs oxygen delivery and neuromuscular function. 4. Acute kidney injury. Hypovolemia and electrolyte derangement reduce renal perfusion leading to prerenal injury. 5. Aspiration pneumonitis, pneumonia. Vomitus can enter airways especially with altered consciousness, causing chemical injury and infection. 6. Mallory-Weiss tear. Forceful vomiting can the gastroesophageal mucosa resulting in bleeding. 7. Rarely-Boerhaave syndrome. Extremely forceful emesis can cause full-thickness esophageal rupture, a surgical emergency. 8. Malnutrition and thiamine deficiency. Persistent vomiting reduces intake and absorption, risking Wernicke's if thiamine depleted. Acid base and electrolytes. 1. Loss of gastric HCl can cause metabolic alkalosis. Repeated vomiting loses acidic stomach contents, raising systemic pH. 2. Typical pattern: hypochloremia and hypokalemia. Chloride and potassium are lost in gastric fluid, with further renal potassium wasting. 3. Volume depletion activates ROS and can worsen potassium, hydrogen loss. Low volume triggers aldosterone, which increases renal excretion of potassium and hydrogen, worsening alkalosis. 4. Assess severity and replace fluids, electrolytes appropriately. Clinical and lab assessment guides targeted fluid and electrolyte replacement to correct deficits. 5. Monitor renal function in significant dehydration. Hypovolemia can cause prerenal acute injury, so urea, creatinine and urine output need monitoring. Initial management: ABCDE. 1. A. Protect airway, suction when indicated. Vomiting increases aspiration risk, so airway protection and suction prevent pneumonitis. 2. B. Assess oxygenation and ventilation. Ensures adequate breathing, especially if aspiration or reduced consciousness impairs gas exchange. 3. C. Assess perfusion, IV access and fluid needs. Checks for hypovolemia and dehydration to guide rapid fluid resuscitation. 4. D. Assess consciousness and glucose. Altered mental status and abnormal glucose may indicate CNS or metabolic cause of vomiting. 5. E. Examine for abdominal, neurological and systemic causes. Full exposure examination helps localize the underlying cause, whether surgical, CNS or systemic. 6. Then identify and treat the underlying cause. Symptomatic control alone is insufficient. Definitive care requires targeting the primary pathology. Fluid and supportive care. 1. Oral rehydration when safe and tolerated. Preferred first line in mild cases as it is physiologic, safe and avoids IV complications. 2. IV crystalloid when oral intake is inadequate or significant hypovolemia is present. Restores circulating volume quickly when vomiting prevents oral intake or hypotension develops. 3. Monitor intake, output and urine output. Tracks fluid balance and renal perfusion to guide ongoing replacement and detect worsening dehydration. 4. Correct clinically important electrolyte abnormalities. Hypokalemia, hyponatremia and hypochloremia affect cardiac and neuromuscular function and must be replaced. 5. Avoid treating the symptom while missing obstruction, sepsis, bleeding or CNS disease. Antiemetics alone can mask surgical or life-threatening causes, so underlying pathology must be ruled out. Antiemetics: 5-HT3 and D2. 1. Ondansetron, 5-HT3 antagonist, common in PONV and acute NV. Blocks serotonin receptors in the chemoreceptor trigger zone and gut, reducing nausea signals. 2. Important adverse effect: headache, constipation, QT prolongation risk. Common GI and CNS effects, with risk of cardiac arrhythmia requiring ECG monitoring in at-risk patients. 3. Metoclopramide, D2 antagonist with prokin action. Blocks dopamine receptors centrally and increases gastric motility to speed gastric emptying. 4. Adverse effects: sedation, akathisia and extrapyramidal reactions. Dopamine blockade in basal ganglia can cause movement disorders and restlessness, especially in young and elderly. 5. Avoid metoclopramide when obstruction, perforation is suspected. Prokinetic effect increases gut contractility, which can worsen obstruction or cause leak in perforation. Antiemetics: H1, M1, NK1 and steroid. 1. Promethazine, cyclazine, H1 antihistamines, useful in vestibular nausea. Block histamine signaling from vestibular system to vomiting center, helpful in vertigo and motion-related vomiting. 2. Hyoscine, scopolamine, antimuscarinic, useful for motion sickness. Blocks muscarinic receptors in vestibular pathways, reducing motion-induced nausea and vomiting. 3. Aprepitant, NK1 antagonist, useful in PONV and selected PONV. Blocks substance P at NK1 receptors in the vomiting center, effective for chemotherapy and post-op nausea. 4. Dexamethasone, commonly used in multimodal PONV prophylaxis. Steroid antiemetic effect enhances other agents and reduces inflammation, useful in combination for post-op vomiting. 5. Consider contraindications, interactions, sedation and QT risk. Many antiemetics cause sedation. Anticholinergic effects are QT prolongation. Support factors and drug interactions must be checked. PONV. Risk factors. 1. Postoperative nausea and vomiting is common and clinically important. Causes patient distress, delays discharge and increases risk of wound dehiscence and aspiration. 2. Apfel predictors. Female sex, prior PONV, motion sickness, non-smoking, postoperative opioid use. These 4 validated factors are the core of risk stratification for PONV prediction. 3. Other contributors. Volatile anesthetics, nitrous oxide, surgical factors and duration. Inhalational agents and longer, high-risk surgeries increase emetogenic stimulus and PONV incidence. 4. Risk increases as predictors accumulate. Each additional Apfel factor raises PONV probability, guiding need for prophylaxis intensity. PONV prevention. 1. Use risk-based multimodal prophylaxis. Tailoring prophylaxis to Apfel score prevents over and under-treatment and improves efficacy. 2. Reduce baseline risk. Opioid-sparing analgesia, appropriate hydration. Opioids and dehydration are modifiable triggers, so reducing them lowers overall PONV risk. 3. Consider propofol-based anesthesia when appropriate. Total IV anesthesia with propofol is less emetogenic than volatile agents. 4. Use combinations of different antiemetic classes for higher-risk patients. Different mechanisms act on separate receptors, giving additive effect in high Apfel score patients. 5. Choose drugs according to patient factors and local protocol. Selection must account for contraindication, QT risk, sedation and available guidelines. Established PONV and aspiration. 1. Assess for dehydration, pain, hypoxia, bleeding, ileus or other causes. PONV can be triggered by non-anesthetic factors, so reversible causes must be identified and corrected. 2. If prophylaxis failed, consider a different antiemetic class. Using a different receptor mechanism avoids repeating ineffective blockade and improves rescue efficacy. 3. Aspiration risk is especially important after anesthesia or with reduced consciousness. Depressed airway reflexes increase risk of gastric contents entering the lungs. 4. Position safely, protect airway and suction when indicated. Lateral or head-up positioning and suction reduce aspiration and maintain airway patency. 5. Treat hypoxemia promptly and evaluate aspirate complications. Early oxygen support and assessment for pneumonitis prevents progression to respiratory failure. Special populations. 1. Pregnancy. Assess severity. Severe vomiting may cause dehydration, ketosis and nutritional deficiency. Hyperemesis can progress to fluid loss, electrolyte imbalance and Wernicke's, so severity guides need for admission and supplementation. 2. Children. Dehydration can develop rapidly, bilious vomiting requires urgent assessment. Small fluid reserve means rapid decompensation, and green vomitus may indicate obstruction needing surgical review. 3. Elderly, frail, great risk from dehydration, delirium and medication adverse effects. Reduced reserve and polypharmacy increase vulnerability to volume loss, confusion and antiemetic side effects like sedation and hypotension. 4. Renal, hepatic disease. Adjust treatment where necessary. Impaired clearance alters drug metabolism and fluid handling, so dosing and electrolyte replacement must be tailored. 5. Patients at risk of thiamine deficiency may require thiamine before glucose. Glucose can precipitate Wernicke's encephalopathy in depleted patients, so thiamine repletion is protective. Key takeaways. 1. Nausea is a symptom, vomiting is a coordinated reflex. Understanding the physiology helps distinguish central triggers from peripheral reflex activation. 2. Always search for the underlying cause. Treating only the symptom risks missing surgery, metabolic or CNS pathology that needs definitive care. 3. ABCDE first in unstable patients. Airway protection, breathing and circulation take priority to prevent aspiration and shock in vomiting patients. 4. Persistent vomiting causes dehydration, hypokalemic metabolic alkalosis and AKI. Loss of acid and fluid leads to volume depletion, electrolyte shifts and reduced renal perfusion. 5. Aspiration is a major anesthesia concern. Depressed airway reflexes after anesthesia increase of pneumonitis and hypoxemia. 6. PONV prevention should be risk-based and multimodal. Using Apfel score and combining different classes improves prophylaxis and avoids unnecessary medication. 7. Use receptor-targeted antiemetics appropriately. Matching drug class to receptor pathway and patient factors ensures efficacy and minimizes adverse effects. Thank you for watching. If you liked this content, don't forget to like to show your support. Comment and share your thoughts. Share with your friends and family. Subscribe for more exciting content. Your engagement means the world to us. Stay tuned for more.